Hi, I'm John Lorraine. I'm the Marcia Sten Professor of Gynecologic Oncology at Northwestern University Feinberg School of Medicine and the Robert H. Lurie Comprehensive Cancer Center. And I run the John I. Brewer Trophoblastic Disease Center here. If you've seen the previous video on gestational trophoblastic disease, you'll know that there's a certain group of patients who are at the highest risk for treatment failure with chemotherapy for these diseases. And those are usually patients who have widely metastatic gestational trophoblastic neoplasia, usually choriocarcinoma, that has arisen after a non-molar trophoblastic, non-molar pregnancy. So I'd like to talk to you now about the importance of salvage therapy or secondary therapy in the management of these high-risk gestational trophoblastic neoplasms. Approximately 30 to 40 patients percentage of patients with FIGO-defined metastatic high-risk gestational trophoblastic neoplasia will have an incomplete response to first-line therapy or will relapse from remission and require salvage therapy. Most of these high-risk patients who fail initial therapy will have multiple metastases to sites other than lung and vagina, will have very high scores, and will have had inadequate initial therapy. The ultimate cure of these high-risk patients who fail initial therapy, therefore, depends on the success of salvage chemotherapy, often combined with adjuvant surgical procedures and radiotherapy. The initial treatment for these high-risk gestational trophoblastic neoplasms is the EMICO protocol that we discussed in a prior lecture. 80% of patients who receive EMICO chemotherapy will go into initial remission. And this has been shown by multiple investigators, including our update in 2006, where we treated 30 patients who had high-risk disease and had a complete response rate of 67% and a 93% cure rate. More recently, we looked at a group of patients who seemed to be at the highest risk, and actually the initial complete response to EMICO chemotherapy was only 54% in our group of patients, but the overall survival was again over 90%. Patients who had a higher HCG level, a longer duration of disease, multiple sites of metastases outside the pelvis or lungs, and very high FIGO scores were at the greatest risk for incomplete response to initial therapy and also for ultimate failure of treatment. We've used a variety of different treatments for those who fail the EMICO chemotherapy protocol, which is our current best protocol for treatment of high-risk disease. And so we've combined etoposide, methotrexate, and actinomycin D with additional etoposide and platinum in the EMA-F protocol. We've combined etoposide and platinum with bleomycin in the BEP protocol, etoposide and platinum along with ifosfamide in the VIP protocol, ifosfamide, carboplatin, and etoposide in the ICE protocol. And we reported on this many years ago, showing that the overall complete response rate to secondary therapy in patients who had failed EMICO chemotherapy was about 80%. We also recognize that those patients who have failed initial therapy, that surgery may be important in their management of their disease. We looked at 50 patients who were treated with the EMICO protocol for high-risk gestational trophoblastic neoplasia at Northwestern between 1986 and 2005, and 48% underwent 27 adjuvant surgical procedures. Most of these procedures were for persistent or resistant disease, and of the patients who had those procedures, 88% were eventually cured, presumably by their surgery and or with or without chemotherapy. More recently, we went and looked at another group of patients to see what kind of salvage therapy improved survival in this group of patients. And we looked at chemotherapy, surgery, and radiation in the management of patients who had high-risk gestational trophoblastic disease but had failed the initial multi-agent chemotherapy, usually Emiko. We had 49 patients sent to our center who completed treatment between 1986 and 2010. 29 of the patients we treated primarily here at Northwestern, 10 patients we treated secondarily with Emiko, and 10 patients had failed Emiko chemotherapy before they were referred in to Northwestern. 28 or 57% of the 49 high-risk patients had incomplete responses or had developed resistance to Emiko. Most of these patients had fairly low HCGs by the time they were referred here to us, but all had metastatic disease, and most had high HCG levels and had all had stage 3 or 4 disease. We used a variety of chemotherapy protocols, including the EMA-EP, BEP, VIP, ICE, and a new protocol called with paclitaxel, cisplatin, paclitaxel etoposide. Paclitaxel is a trade name is Taxol, so the TPTE protocol. And we very often had to use growth factors or granulocyte colony stimulating factors called filgrastim or pegfilgrastim to prevent neutropenia and treatment delays when using these drugs. We used 11 operative procedures in these 28 patients to remove resistant foci of disease, including hysterectomy or pulmonary resection. 4 of the 28 patients developed brain metastases during treatment and got brain radiation, either whole brain radiotherapy or stereotactic radiation. We treated these patients with a total of 46 different chemotherapy protocols and had a complete response rate of 63% and an overall survival of 82%. And you have to remember, that's in patients who have already failed the initial treatment. Of the patients who had hysterectomy, all cured. Of the patients who underwent pulmonary resection for resistant disease, 9 out of those 11 patients, 9 out of the 11 total patients we treated with surgery were cured of their disease. Even patients who developed brain metastases during treatment, we were able to cure 3 of the 4 of those patients. We found that those patients who had the relatively low HCG at the time of treatment as secondary therapy did better, and those patients who had fewer metastases had only stage 3 disease compared to stage 4 disease and had lower FIGO scores tended to do better. So patients with high-risk GTN who have responded to Emiko but have plateauing or relatively low HCG levels or have developed a re-elevation of their HCG levels after complete response to Emiko should be treated with the EMA-EP regimen. Of 19 patients in this series treated with EMA-EP, 47% had a lasting complete response. Patients with persistent or recurrent high-risk GTN who have developed resistance to methotrexate-containing treatment protocols, such as the Emiko regimen, should be treated with drug combinations employing a platinum agent and etoposide in combination with bleomycin, ifosfamide, or paclitaxel. Of the 19 patients treated with these protocols in our series, 74% had lasting complete responses. Adjuvant surgical procedures, especially hysterectomy and pulmonary resection for excision of chemotherapy-resistant disease, are important components to salvage therapy. 39% of patients in our series had surgical procedures to remove resistant foci of disease, 82% of whom were cured by that procedure. Brain irradiation should be used for patients who develop brain metastases during treatment. 3 of the 4 patients in our series who developed brain metastasis during treatment and received brain irradiation survived. Survival with salvage therapy was significantly better in patients with relatively low HCG levels at the start of chemotherapy, number of metastatic sites 2 or less, and stage 3 versus stage 4 disease. Salvage therapy with etoposide and platinum-based chemotherapy regimens, often in conjunction with surgery to resect resistant foci of disease and/or irradiation to treat newly developed brain metastases, was responsible for achieving cure in 82% of the patients who failed initial multi-agent chemotherapy, and 53% of the 43 high-risk patients in our series who were eventually cured. Thank you again for your attention.